Testing, testing.
Welcome. I'm Terry Roselle with the Department of Bioethics and the Center for Practical Bioethics. Welcome to those of you who are watching on YouTube. We're here at KCU, and we have mostly second-year students who are to sign in, sign-up sheets that are going around. If you have not signed in, you'll want to do so. So please do that. About 8 years ago, Dr. Andrea Chatburn was sitting where you are now. Second-year student, 8 years ago, about right now. She happened to be a second-year student who had also signed up to do the dual degree program, so she was working on an MA in bioethics as well as the D.O. degree. And I remember her intro to bioethics class 8 years ago. And I remember her because she was a student who was incredibly curious and interested and respectful and aspired to be not only an excellent physician, clinician, but one who was also ethically aware and attuned and practicing ethical medicine. About 2 years ago right now, I remember getting a phone call from Dr. Chatburn because she had gotten an ethics consult. She was doing a palliative care fellowship program in a hospital who had also recruited her to do ethics consultation while she was working on her palliative care fellowship. And Dr. Chatburn called me about one of many cases that she was the lead consultant on during that year. And one that I remember, because we talked about it a little bit just the other day, involved an elderly couple who had come in. The woman the wife was the primary caregiver for her husband, who, as I recall, had some dementia, early stages of dementia, and the wife had just gotten a diagnosis of cancer, which she presumed to be terminal, and therefore presumed that something needed to be done, because what would her husband do without her? And so she planned a way of escape for both of them. And initially, they both took a high dose of some kind of medication, expecting that they would not wake up. But they did wake up. It didn't work. And so another plan was put in place in which they would inhale a large amount of carbon monoxide. But they also woke up and panicked, and someone called 911. And they came into the hospital where Dr. Chatburn was on call for ethics. And the call for ethics included questions about how do we deal with this situation, not the clinical medical parts of it. We know what to do with that. We know how to treat the injuries that resulted from suicide attempt. We also know how to go about assessing and perhaps treating the cancer. But what do we do about the other dimensions of this case that involve something more like ethics? Do we do a involuntary psychiatric admission? Is this suicidality? Is this homicidality? How do we relate to her relative to him? What do we do? These are ethics questions. And the way that Dr. Chatburn handled that situation and numerous other situations that involved ethics as well as palliative care meant that she was recruited by more than one institution when she finished her fellowship and eventually landed a job that is her dream job in Spokane, Washington, where she works for Providence Healthcare and spends about 50% of her time as a palliative care physician and about 50% of her time as director of ethics for Eastern Washington, for Providence Healthcare in Eastern Washington and Montana. And we bring her back here to talk to first-year students about the dual degree program, which she did yesterday. And today, as our guest lecturer in the lecture series in bioethics, today she'll be addressing issues about end of life. And I'd like for you to welcome, with a good KCU welcome, Dr. Andrea Chatburn.
Thank you so much. I'm going to do a little test here and see if we can go back and forth with this. We can't. So I'm going to stand behind here, and I apologize. I'm a short animal. So there's a large screen. I'm a short animal. I do need to advance my slides in some way, shape, or form. So I'm going to be behind here, but I apologize. That's not my preferred way of being. It is a pleasure to be here with you. I want to thank particularly the bioethics dual degree students who have shown me around this morning and have stimulated discussion. So when stakes are high and emotions run strong, often this is where we find the ethical dilemmas at the end of life. I do want to acknowledge that I currently work for Providence Center for Healthcare Ethics, and as a collaboration between multiple clinical ethicists, many of the things that you'll see together are not my work alone, but as a collaboration between several of us. Great resources if you're looking particularly for patients with algorithms for how to deal with patients with diminished capacity to make decisions, maybe not lacking decision-making capacity, and then the feasibility of care, great resources. So, and these will be available to you afterwards online as slides. Today we do have many objectives. If it's all right with you, I'm going to go ahead and proceed forward without going over the objectives, but they are there. Just a reminder regarding cases, I am going to talk about one case in particular, and I want to make sure that we recognize that cases are based on actual people. Details, ages, initials are changed, but these are stories that affect real people, real families, and just from the unique nature of ethics dilemmas and cases, they are sometimes identifiable. So I do want to make sure that we honor the patient and the family behind the case. I also want to acknowledge that the cases presented as is may not provide all the information that you want. And sometimes that can be frustrating, but that's also part of the process of asking, what more do I want? So hang in there with me. I don't have anything to financially disclose, but I do want to acknowledge that the title, When Stakes Are High and Emotions Run Strong, is a fairly typical saying of one of my personal mentors, Dr. Lindy Lanzat, who also is an alum of this institution, I believe in 2005, and is currently the Palliative Care Fellowship Director at the University of Kansas. Another of her favorite sayings is that when it's personal, all bets are off. And I want to acknowledge that sometimes when we talk about end-of-life ethics cases, it brings up cases within your own life, your own experiences, and your own family that trigger emotions that you may not be expecting. And I want you to feel free to acknowledge those and do what you need to do to give that space as we're discussing this. We will not, there are many, many ethical dilemmas at the end of life. We can't discuss all of them at this point. We're going to focus on a very narrow set of a very common dilemma that we face. I do want to acknowledge that there are many members of the military here today, and that there are many ethical dilemmas at the end of life that pertain to that, but those aren't some of the things that we'll be able to talk about today. Those would be in another lecture. I also want to acknowledge that sometimes the end of life is far too close to the beginning of life. And those are certainly ethical dilemmas that come up within everyday care of palliative care, but that's not a topic that we'll have time to spend time on today, but I do want to acknowledge that. The other thing that is fundamental and foundational to ethics at the end of life is how to determine whether a patient has the capacity to make a decision, or is there a surrogate decision maker who needs to be making this decision for them? Is their surrogate decision maker capable of making a medical decision? And informed consent can be, and shared decision making can be very complicated. I could go on for a whole nother hour simply about informed consent and surrogate decision making. So I do want to reference that and acknowledge that there are many more layers to the dilemmas that we talk about when we talk about end-of-life care. Some very common ethical dilemmas at the end of life include code status. Is CPR going to be beneficial? Is it going to harm them more? Would they want it? Do they not want it? But we do think it would be beneficial. How do we negotiate what interventions ought to be offered, what interventions are being offered, and how we proceed when we're at a stuck spot? Often ethics gets involved in patient care when we're going along in our medical care according to clinical integrity, and suddenly we come to a halt. Emotions run strong, and the stakes are incredibly high. And here we are, we're stuck. How do we move forward? And so I'd like to propose a framework for a way of thinking about medical cases in end-of-life care. When we get to the stuck spot, how do we move forward? So we're going to do that by looking at one case in particular. I do want to look at a way of mapping. We call this the, quote, Providence model for healthcare ethics. I do want to acknowledge that this is based on Al Johnson's clinical ethics 4-box model. There are many, many 4-box models, Potter boxes. There are, throughout ethics, ethicists really love 4-box models. It's just it's a nice way of putting out there what's going on and drawing upon different sections of healthcare principles. So from this is actually John Toohey, one of my colleagues, kind of put together a way of mapping ethics cases not as a way of weighing, but as a way of drawing a map for acknowledging some of the things that may be going on in this case that we wouldn't necessarily name out loud, things that are both inherent and obvious, and things that are running underneath the surface that everyone understands but no one is saying. So a way to bring to the surface and a way to acknowledge what's going on, and then use that as a map or a guide for how do we move forward. So this is a blend between organizational ethics with Laura Nash and Al Johnson, looking at clinical integrity, and that'll mean something probably I hope to the clinical or the bioethics master's students. Don't worry about that for the rest of you. So we're going to look at a case from each of these 4 layers and areas. And so within this, the goal is to promote, within clinical integrity, we want to promote honesty in representing right professional practices and the delivery of healthcare. We use many things to inform that, including clinical practice guidelines, things like choosing wisely that we'll talk about later. Dependability. So when we look at beneficence, and we'll look at that deeper in a second, we also look at what can the patient depend on benefiting from in this clinical situation. Fairness to the patient from within their own psychosocial, clinical, ethical, religious, economic situation, not from fairness to them from our biopsychosocial model, but from theirs. And then accountability, so justice and non-maleficence, so looking at accountability and fairness to the legitimate interests of others, including the patient as a member of a greater healthcare system and a greater community. As with anything, these overlap in many places, and underlying all of it is the therapeutic relationship between the patient and the provider. The therapeutic relationship between the patient and the provider. And in that way, we can listen to the stories, we can bear witness to the suffering that's going on, we can hold the hopes and fears of our patient in a narrative that we're able to share with our colleagues and other caregivers in a way for finding out how do we move forward. So that narrative helps inform how we move forward. We also want to make sure that we're looking at clinical context. So within the context of each clinical case, when we look at benefit, or what can the patient depend on benefiting from? What can they depend on benefiting from in this clinical context? We have to look at what their clinical context is. So is this an acute situation where what they can depend on is getting a rescue or getting a fix? That's what we all want, right? But the reality is that in medicine, so often what we're really looking at and what we can hope to offer is chronic maintenance therapy. In other situations, we're looking at palliative, and this has a big P, but I would suggest that this is a little p palliative. So all we can hope to do is alleviate their symptoms or enhance quality of life. The patient can no longer depend on us maintaining their chronic diabetes or fixing their acute pneumonia because it's happening over and over and over again. So that would be an example of being in the palliative setting. Are we simply in a situation that all they can depend on is prolonging biological life, and we can no longer even alleviate their symptoms or enhance their quality of life? Those situations are rare. Are we in a futile situation or a non-beneficial situation where all of the technology that we have to offer isn't working, or maybe it's even harmful? So where are we at? So this is the question mark at the beginning of the map. This is the question mark at the beginning of the story as we sit down knee to knee and eye to eye and hold their story. So we're going to talk about Mrs. C. Ms. C is an 88-year-old woman. She was admitted to the hospital from her skilled nursing facility. She was combative. She wasn't eating. She was hitting and punching. She was refusing even assistance with showering and dressing, simple things. And she's been combative for a while. This has been going on for about a year. And every time this happens, she kind of comes into the hospital, and then she looks at going back. She looks at going back to another nursing home. And by the time I meet Ms. C and her family, she's been in 15 nursing homes. She has advanced dementia. They're not sure what type of dementia. They're not sure if it's Alzheimer's or if it's Lewy body or if it's due to Parkinson's. They think that it's probably just typical senile dementia. But she's at the point where the things that she can do are accept a toothbrush going into her mouth. She can say things like, "I'm hungry," or "ow." She can say, "I want," but not finish the sentence. And she can certainly let us know what she thinks about the things we're doing to her by the behavior that she's showing. So that's Miss C. So the fact that she has advanced dementia and she's saying about less than 7 words that are meaningful on a regular basis. Now that's not including when she's singing the hymns. and she can sing all of those hymns. So she can do that when you turn on the radio. But that puts her in a specific prognostic category that we'll talk about in a little bit. She's losing weight. She's maximally cachectic. You can see the outline of her musculature and between the interosseous areas in her hands. Her abdomen, when you listen to her stomach, is soft, but it's just scaphoid. She's tiny. She's frail. So clinical integrity. So when we're using this map to outline how ought we move forward, as we're listening to the story, and we map out the different things that we learn within clinical integrity, we're going to focus here first for Ms. C. So for Ms. C, we start by looking at my relationship. So when we're looking at relationships, when we think about ethics answering the question, how ought we be with one another? How ought we be within our social situation? One of the things that clinical integrity asks is, how ought I be within my profession? So what is my relationship to my profession? So for Ms. C, how do we make a care plan when we're not necessarily certain about her diagnosis or prognosis? So we don't know why she's acting out. We don't know if it's just because she doesn't want to do something, or if she has a urinary tract infection or a new pneumonia. We don't know. What are the care options that should be offered? And what guides us to that point? What should we do if Ms. C's goals and her family's goals seem inconsistent with what the traditional goals of medicine are? Goals of medicine being to promote and return people and patients and families to wholeness of functioning, to prevent preventable diseases, to avoid or prevent an untimely death. How do I resolve professional issues? Is there coercion involved? Are we telling the truth in each of these situations? Are there conflicts of interest? Not all of these come up with Ms. C, but that gives you a flavor of what are the things that we're asking when we're mapping out what does clinical integrity look like for Ms. C. Autonomy. Who is Ms. C as a person? How do we get to know who she is? And how do we get to know what her context is? What would be a good outcome for her? What has she already said about what she wants for her body? So we know that she's 88, so that tells us that she sits within a generation. So we can make generational generalities, but we want to make sure that she fits within the global or the community things that we expect. So we ask. We know that Ms. C is a lifelong devout Catholic. She's been a homemaker most of her life, but she's very, very proud of what she's been able to do. She's a great cook. She often cleans. She's very giving and generous, and she's been involved in her church. She has 5 children, 3 daughters, 2 sons, and she's widowed. She's been widowed for 20 years. How does Ms. C express her autonomy? So Ms. C, when we talk with her and we ask her tell me about you. She says, oh, honey, thanks. And we don't get very far. So we start asking her daughter's at the bedside. Her youngest daughter is her caregiver. And so we start asking, tell me about your mom. Who is your mom as a person? What has she been like throughout her life? What are the decisions that she would have been or how would she have talked about this if she were able to talk about this now? Did she ever talk about what she wanted for herself? So when we look at the ways that different patients express their autonomy or their ability to make decisions for themselves about their body, we look particularly to the Patient Self-Determination Act, which in part says that patients have the right to put down on a piece of paper. Now we're starting to look at what does it look like if they record a conversation on their iPhone between their loved one about what they want? What if they were to record on their phone a conversation between them and their loved one or the person they trust the most to make decisions for them if they can't? What does their facial expression look like as they're talking about the things that they want? So there are you will see that there are many different ways of expressing your wishes. There are many community events, Death Over Dinner, the Conversation Project, 5 Wishes, respecting choices, caring conversations. There are many different ways that we can get to the conversation of what would you want done for yourself if you weren't able to speak for yourself. How many people have an advance directive right now? Raise your hands high. Maybe about 30 to 40. Wonderful, good work. Right now I teach a Gonzaga ethics internship. It's a small Jesuit liberal arts university. And I have a clinical ethics intern who sees patients with me in the hospital every Tuesday morning from 7 to 10. And when we started to talk about advance directives and I asked her if she has an advance directive, I got the most interesting response that I've ever gotten when I asked that question. And she said, "Of course I do. I drive a car." She said, when I turned 18, she grew up in the middle of nowhere, Wyoming, and she said, when I turned 18, my parents sat me down and they put a type of advance directive in front of me and they showed me their advance directive and they said, because you drive a car and because we love you and respect you and because unfortunately bad things happen to good people, we want to know what you would want for yourself if you were to be in a car accident and not be able to speak for yourself. We want to be able to respect that, and we want to be able to respect if you don't want us making the decision. So they had her name a durable power of attorney or someone she trusts to make decisions for herself if she can't, and had her just look at what would she want for herself. It's typically not an immediate reaction. It's a decision-making process. It's a conversation starter. And so she filled one out, and then her parents proceeded to tell her that if they were both in an accident, they would want her to make decisions for them if they weren't able to. Hard conversations. Emotions are running high. We're actually asking people to imagine the unimaginable. And it's hard. Your heart's racing, your palms are sweaty. Sometimes you get tearful. It's easier to not do, but it's so important that we do it. So Ms. C had filled out an advance directive. She had some conversations with her oldest son. She hadn't really had conversations with the other kids. She had named 3 of her 5 children as joint durable powers of attorney for healthcare. She didn't have, so POLST is Physician Order for Life-Sustaining Treatment. TPOP is a Kansas City initiative between Kansas and Missouri, Transportable Physician Orders for Patient Preferences. And both are ways of expressing to the community if a patient and a physician have a conversation and end up deciding that, CPR or intubation, if you're found to be without a pulse, may not be the best thing or may not be what you want for yourself. So this is a way of saying to EMS or the ambulance service when they're found, hey, it's okay. The default is CPR, but not here. So she didn't have one of those, but she made it very clear in her advance directive that if she had a terminal illness, does she have a terminal illness? We're not sure yet. If she had a terminal illness, so if she had an illness that she knew that she would die from, that she would not want CPR. She wouldn't want to be in the ICU. She wouldn't want to be on a breathing machine. And so that was the next step to expressing her wishes. So here she is. She has her advance directive. Like I said, she named 3 of her 5 children as joint durable powers of attorney for healthcare, or as her surrogates. Every state has a different way of determining who is someone's surrogate if they don't have a durable power of attorney for healthcare. I'd recommend looking at your state statutes. In Washington, it automatically goes to the spouse, a legal spouse, and there is same-sex marriage in Washington. So a legal spouse includes a same-sex couple. Adult children making decisions unanimously together. So if she hadn't filled that out, all 5 of her children would have had to make decisions together. So be thinking about this as you're going through, going, I don't know if I would want that person to make decisions for me or not. I'm not sure. I know that for myself, in my own family, my mom told my father, I don't think I could make decisions for you based on what I know you want. If you were ever in that situation, you need to choose someone else to make that decision. And so I am my father's durable power of attorney because my mom says, that's something that I don't think I could handle. Then it goes to, at least in Washington State, it then goes to adult children, spouse, adult children, then to living parents, and then to adult siblings. And if there's no one within that, so people who are, quote, unattended or unbefriended, or people who have, that's a horrible term. It makes people, to say that someone is unbefriended is a very lonely term. But truly there are people, and I'm sure that you know many of them, and I know that you will meet many of them on your 3rd and 4th year rotations, who truly are either estranged from their biological family, or they have a family of choice, or they just have a small family and there's just no one that falls into that category. Maybe it's someone who never married, never had children, has nieces and nephews, but they live far away. What then? So back to Ms. C. So on Ms. C's advanced directive, there's a section in there that talks about artificial hydration and nutrition. Sometimes you'll see that as AHN, and it has 2 boxes that to be checked. One box says, I would want artificial hydration and nutrition. The other says, I would not want artificial hydration and nutrition. And for Ms. C, neither box is checked. So we don't know what she would have wanted. There is fine print that is in about 8 or 9 font that says at the bottom that if neither box is checked, the default is to give artificial hydration and nutrition. This form was filled out in 1989. It is the most recent form that she has for herself. And when I ask her daughter, who's sitting at her bedside, do you think she knew this was there? Do you think that she knew that this was the requirement? She says, gosh, I don't know. Mom typically has pretty good eyes, but I don't know that I can even read that. I'm not sure. We don't know what Mom would have wanted. So here she is. She has 5 children. Her oldest daughter's in Maryland. She's one of the children that was named as her durable power of attorney. Her 2 sons live within an hour of where Ms. C lives, and they also are named as her durable powers of attorney. Her youngest daughter is her caregiver, and who sees her day in and day out at the nursing home. She's not named as a durable power of attorney. She is who is omnipresent at the bedside and who's talking with the doctors every day. Her children are pretty split on what to do, and it's hard to even get them to come to the table to talk more about it. Because if you remember, she's been to more than 10 nursing homes over the course of the past year because of not being sure about what to do. So I want you to take the next 3 minutes to turn to the people next to you and talk about, so you're the clinical ethicist, you're the physician who's taking care of Ms. C. How do you move forward? How do you determine what happens next? How do we resolve this conflict or seeming conflict about whether or not we should help this 88-year-old woman eat more or help her control her agitation or help her in ways that support what could be a natural dying process? Go ahead and take 3 minutes with the 2 closest people next to you. the next slide that's up, if you're having trouble figuring out what to focus your conversation on, pick one of the items on the next slide. How are you? Good to see you.
Good to see you too.
Likewise. Doing well. Thanks for coming. Yeah. Feedback so far?
Well, I mean, I should probably go mostly the cultural and religious and ethnic point of view. I mean, if
Yeah,
the
please.
person's, for example, my mother was Alzheimer's disease in the almost the last stage. Last 13 days I was with her, and then very first day she recognized me, then every day she declined. But I mean, we know that the end is near. We tried to just to be with her. I was just feeding normally. Then next day, she couldn't. She refused it. I tried several times, but I didn't force. I know that end is coming. Just to make her more comfortable. We didn't go with this. What is this? The power of attorney or something?
Yeah. Well,
I mean, because
it's
it's
not always
yeah.
Yeah, it's not always necessary. Yeah, that's ideal
It is yeah.
when everybody's on the same page.
That is
You recognize the physicians are willing to make sure that
yes.
we're working close to the end.
Yeah.
This is how we actually make her try something she wants and she wants it. Let her have it. If she doesn't, then we'll continue. Yeah, perfect. Love it. Good.
So how do you enjoy? You love it?
I love it. Yeah.
So where is your home state?
Washington.
Washington. Okay, so you are pretty back home.
It's very good.
Yeah.
And you?
My home state's in Turkey, so
Yes.
then I've been here for 26 years.
Wonderful.
Yeah.
Kansas City is the whole
Yeah,
time?
all them Kansas. Yeah, that's my second home.
Yes, it's true.
Yeah, you should come down time to time.
I love that. All right, we're going to go ahead and wrap up the thought you're on right now. And if I could get maybe two or three groups who are brave enough and willing to share, what do you think? How do we move forward? What did you talk about amongst yourself? What were the concerns that you had?
So we talked, and maybe this is us not understanding, first of all, the disease well enough of all time or whatever she has, dementia.
That was intentional. Sorry.
It's a little bit, to us, she seems like she's still up, she's still walking around. It's hard to kind of grasp that she's actively in a dying process.
Sure.
Which it makes it a lot tougher saying to not give food and not give the treatment that is like we feel like it might feel like it's starving her.
Perfect. That's exactly the point that her oldest daughter brought up. Her oldest daughter said, I'm really struggling with this. I feel like I'm starving her. Yeah. Who else? Brave souls. Yes.
So we felt like if she can't eat on her own or won't eat on her own, then that's the choice that she's making. And so to try and force food on her it seems like that's going against her will. But we also talked about since there's no consensus amongst the people that are on the durable power of attorney, that we would want to do it seems like then the decision is up to us. What do we as doctors do that like fits our own conscience and feels the right thing to do and that we won't get sued for? So we figured the most conservative would probably, course of treatment would probably be best. So default to keeping her alive, prolonging, like giving her food. but also do what is going to make her caregiver make life easiest for the caregiver. So give default to giving anti-agitation drugs.
Sure, absolutely. So we start anti-agitation drugs. She's a little more calm, a little more sleepy. That's exactly the point that we're gonna put on the shelf the concern and the fear deep down about being sued, and we're not gonna talk about that within our ethics conversation. But with her son is saying, I feel like she's choosing. Both of her sons say, I feel like this is what she's choosing, and why don't we let her eat what she wants to? And her daughter, who's the caregiver, who's not a durable power of attorney, the youngest, is saying, yeah, I'm trying. I meet her at lunch every day because the staff at the nursing home can't do it anymore. They're trying. They feel awful. She spits it back out. It's not working. But she says, but I feel awful about it. Both ways. Yeah, absolutely. Yeah. What else? One more? Yeah.
So we thought a good idea would be to contact the family and let them know that we're there as a resource, and we advise them to get together and to make a decision, because otherwise natural courses may just make a decision for them that's something that they won't like.
Her body's making a decision for her. Could be. Okay.
Yeah, and just explain that, we want them to do this. We recommend that they do this. So that they can make a decision instead of just letting whatever happens.
Sure. Wonderful. So process recommendation. Perfect. So we have a family meeting. We consult the palliative care team, and we talk about what matters most to her. We ask questions like, what would she say if she were able to be here right now? We ask questions like, what will it look like to feed her or not feed her? How? And so we bring them to the table, all children together, including some of the spouses. One son says, no, I've talked about this already too much. I disagree with my oldest sister. She knows what I think, and I'm not even coming to the table. You all know what I think already, and I think we need to let what's happening happen naturally. So then where do we go? So autonomy asks questions like, does the patient understand what's wrong? And for Ms. C, we have no idea. She can't tell us. And so she can't make a decision on her own, but she certainly is showing us with behavior at least what is going on with her right then. Turns out she doesn't have a urinary tract infection. She doesn't have a pneumonia, but she did have a pneumonia not too long ago, and they think it was an aspiration pneumonia with her swallowing. And it asks questions like, what's my patient's cultural, religious, or ethnic point of view? And asks questions like you had mentioned, can the patient, can the family engage in the care plan? Either way, what would it look like? Is it feasible? Who's the support system? Who's really going to be there? It also, then we launch into beneficence. So what can Ms. C depend on benefiting from, whether we're doing hand feeding or tube feeding? So it asks things like, am I fixing what's wrong if I can? Well, we've looked. There's nothing to fix right now that will provide a cure. Can we maintain what's going on? We might be able to. So could the peg tube maintain what's going on? Maybe. And then it starts asking questions like, are we benefiting? What can the patient depend upon to benefit? So then we start looking to guidelines. So this is where there's the interplay between clinical integrity and beneficence. So choosing wisely is an initiative of the American Board of Internal Medicine that asks each specialty in medicine to look at the top 5 things that are routinely done that they should start questioning, that patients and families should question, because it's not clear that there's good evidence-based medicine that there is a benefit in certain situations. So we're gonna, right now, Okay, we're in the interest of time. There's excellent video describing palliative care because you had mentioned let's process and have a family meeting. So palliative care with a big P, so palliative care is a specialty, is a medical specialty focused on pain and symptom management and improving quality of life for patients with serious illness at any stage and any age. Sometimes that happens at the end of life. The root of the word comes from palliare, which is Latin, meaning to cloak or to comfort. Often it's referred to as an extra layer of support. So here you are, you're in the hospital, you're sick, it's serious, there's many things going on, so we're going to be an extra layer of support and hopefully tie systems together. It can happen at any point along the disease spectrum. So if we're looking at prevention, curative and life-prolonging treatment, so this is when we start looking at the clinical context. And once symptom management happens along the way, bumps and bruises, for instance, you break your arm, we're going to be managing those symptoms. But then as we start getting towards that pyramid towards the end, where curative options are getting less and less, and life closure looks like it's possible, even if we get a curative option and we're cycling through kind of the area that's in between illness and death, palliative care can be, specialty palliative care can be there as an expert consultation on both communication and symptom management. Palliative care is the big circle. Hospice care is a specialized part of palliative care that happens at the end of life. And that, again, is a whole nother lecture. And I hear that you've had wonderful lectures lately from palliative care physicians on the differences between palliative care and hospice. So I won't go into that. Justice and non-maleficence. So what is my relationship with others in this? And so the word O can be kind of awkward in this point. But most importantly, we hear the nursing homes in this case saying, this patient and my staff are at risk for being hurt. How do we manage this? Do I have an obligation to prevent harm? How do I prevent harm? Are there conflicts of interest? Is her insurance saying you can only go to X, Y, and Z nursing home and not that nursing home, but one is being paid by the other? All sorts of questions. It's a pause. It's not a yes, no. It's not a stop sign. It's not a directional sign on a map. It's simply a pause or a yield sign or consider this as we map it out to bring to light things that are below the surface. So when we're talking about justice and distributive justice at the end of life, we also look at access to primary palliative care. Primary palliative care is the palliative care that every physician can do, regardless of the specialty. It's the sitting down and asking, what matters most? What do you hope for? It's inherent in every part of primary care specialties, in ER, in oncology, which does this frequently and does a lot of palliative care. This is the communication about treatment options and pain and symptom management that happens every day between doctor and patient, and the conversation should be built into regular visits. So access doesn't necessarily mean access to specialty palliative care services or consultations unless it's indicated, and we'll look at that in a little bit. So, and this acknowledges that there are changing medical attitudes about death. Death isn't a failure on the part of the physician. It's part of something that all of us will go through. Atul Gawande has written a beautiful new book called Being Mortal. And Angelo Volandes has written a similarly beautiful book entitled The Conversation, a profound and innovative new way to talk about end of life. So death is a natural part of life, and the goals of medicine say that we ought to prevent an untimely death. Now, timing doesn't mean necessarily, certainly being at the end of one's natural life right before a granddaughter's wedding is incredibly untimely and unfortunate, and it's not ideal. But untimely in this sense means a death when someone has come to the natural end of their life. It's questioning what are the technologies that are appropriate at this point. It also looks at, when we talk about social justice, we also look at bankruptcy. Bankruptcy is not infrequent in patients that have extended hospital stays in the last 3 months of life. So one thing that choosing wisely does is helps us ask what ought be offered, what's going to be beneficial. So one of the things that's recommended at this point is not to recommend percutaneous feeding tubes or PEG tubes or G tubes or feeding tubes in patients with advanced dementia. Instead, offer oral assisted feeding, because new evidence-based medicine has shown that in dementia specifically, not necessarily in other diagnoses, but in dementia specifically, there is no survival benefit between those who have a PEG tube and those who don't. There's no nutritional benefit as far as wound healing, as far as energy goes, in those who have artificial feeding and those who don't. But it feels very different. Like you mentioned, it feels like we're starving her. Oldest daughter is saying, it feels like we're starving her. We absolutely can't do this. This isn't consistent with mom's Catholic faith. What do we do then? Turns out when they talked with multiple priests and we invited them to the family care meeting, they said, no, at what point are we delaying her entry into the afterlife? But it's hard with dementia. You mentioned that it doesn't look like she's actively dying now. And you're absolutely right with dementia. So she's speaking 5 to 7 words or less. So that places her in a prognostic category that says that on average, most people have a prognosis of 6 months or less, which would qualify her for hospice if her goals are consistent with hospice. But that recognizes that some live longer than that. And so what does that look like when we're talking about things like food? We love people with food. We have food at our baby blessings, at our births, at our birthday parties, at our weddings, at our celebrations, at Thanksgiving, at our holidays. Everything that we do with family and being a community is usually centered around food. So what does that look like? How does it feel? I'm going to go quicker through these. You'll have access to them on your slides in retrospect on the internet. But there are many different statements from many different medical specialties that make comments about what can the patient depend on benefiting from at the end of life. And this is new information from a clinical integrity standpoint. These are some common reasons that people ask for a specialty palliative care consult. When they have symptoms that can't be controlled even after their primary doctor, their admitting physician have tried. When goals of care can't be clarified and there's still conflict, there's still a stuck spot, even after routine conversations have happened. So back to Ms. C, should a feeding tube be placed? So I'm going to take a poll of hands. And I want you to base this on from what we know about Ms. P, from what we know about what her family said, from what we know about her disease now. Would this be Ms. P's most likely desire? And who decides? Would tube feedings be clinically appropriate? Would the family see this as a good outcome? So how many people think that, so we'll go through these each individually. Feeding tube is in. We think that Ms. C would want a feeding tube based on what we know about her. How many people say, no, I don't think that she would want that based on what we know about her? Sure. How about, who decides? How many people say, well, we need to go with her durable powers of attorney. The three siblings need to come to some consensus versus, let's say, the court or the hospital deciding. So children deciding, court or hospital deciding. Would tube feeds be clinically appropriate? Yes, no. Tube feeds clinically appropriate? Tube feeds not clinically appropriate for her. Yeah. So these aren't easy answers, and they're so complex with multiple layers, and so that's why we map this out. But asking the question and listening to the story is what helps us navigate to the end answer. And then what would the family see as a good outcome? Turns out when we asked the family, when we asked all 5 children, how do you see this going for your mother? What would you consider a good outcome? Every single one of the 5, including the oldest daughter, said, ultimately, at the end of the day, we want to make sure that she's comfortable and has a comfortable death. But how they defined that was very different. Oldest daughter felt very strongly that a comfortable death meant that she wouldn't, in her mind, be starving. And in her other children's mind said, well, it would be most comfortable to not force it. And so they all want the same thing. They have different ways of getting there. Different ways of getting there. A note on Catholic healthcare. So Catholic healthcare has a deep respect and promotion for the sacredness of all human life and creation, from conception to natural death. And when we talk about things that are extraordinary versus ordinary, there are every area, every bishop, every scholar sees it differently, but in general, within the Catholic ethical and religious directives, if at this point families said, you know what, we don't want to continue with tube feedings because it's simply too burdensome, we don't see a benefit, that would be certainly permissible. So from the patient's perspective, any intervention that has undue burden or side effect, they can decide to do that or not do that. So finishing the story for Ms. C, she has increasing agitation in the hospital despite adding additional antipsychotic medications. She's no longer somnolent, but she is more agitated. She's now grimacing and moaning. She's tensing. She looks uncomfortable. She's squirming. She's no longer able to get up and out of the bed. And we're not sure what's causing it. When we try to do an exam and figure out where she's hurting, it's kind of everywhere. Daughter at the bedside, youngest daughter, daughter who's the caregiver, who sees her every day, says, I don't want mom getting any pain medicine. She's already on antipsychotic medications, like I said. And then we find out so we've been talking about 4 of her children, and we find out that there's a 5th daughter. So we knew there were 3 daughters, but we've only heard from 2. We've never seen the 5th. And it turns out the 5th daughter has had a history of drug abuse. And so that's informing what's going on. And she's not in the picture. No one talks about her. No one says where she is. And she's almost invisible. And when we start talking about how do you see pain medications in your mom, her youngest daughter, who's the caregiver, says, I just don't want her to get addicted like my sister was. And so then we talk about how she's not going to get addicted. There's certainly a stigma that we need to recognize, validate, acknowledge, but provide a framing that says that this is a completely different clinical situation that your mother's in than your sister has been in. So in moving along, I do want to touch briefly on responding to intractable terminal suffering. So responding to suffering that's at the end of life, that despite quality and evidence-based symptom management for pain, for agitation, for nausea, symptoms still aren't being controlled. I do want to touch just very briefly on the fact that when we look at specialty oncology and palliative medicine, there are several things that come up as far as options of last resort. Several options of last resort, which are available everywhere to anyone in any state, within good clinical integrity and specialty palliative care are things like palliative sedation, so sedation to unconsciousness for terminal suffering when everything else has been tried and nothing else is working. It's something that ought to include a very detailed conversation with family, with goals in mind, with is this a fitting response for this person, and recognizing that that the way of being with one another may be compromised with this. They may not be able to interact in ways that we may or may not know they may be able to. The other one that individuals can choose within their own context, and there's a lot of controversy around, is voluntary stopping of eating and drinking. That came up in an advance directive with an attorney, I believe, from New Jersey just about a year ago. So there are conversations around those options. Those I would recommend including your friendly bioethicists who are among you. And talking more about those. But there's a recognition from Dr. Tim Quill and Dr. Byack that medicine certainly can't sanitize or provide perfect solutions for all clinical dilemmas. When unacceptable suffering persists despite standard palliative care measures, terminal sedation, voluntary refusal of food and fluids, they're not perfect. They feel awful. They could be useful last resort options for some patients. And so those are things that if you're interested in talking more about and the practical application and the rare use of those, I'm happy to talk about later. Those are an entirely different hour-long lecture that I think is stimulating and important to have. So it's an acknowledgement. So there's certainly a lot of controversy right now around end of life, particularly with California recently legalizing physician-aided dying, and in other countries, euthanasia being actively practiced. I do want to recognize that I work in the state of Washington. I work for Catholic healthcare. It is not an option that's available within Catholic healthcare, but it is something that is out there. It is rare. There are good narratives that walk through what is it like for patients who are curious about this option, want this option available, or go through this option. And so I'd refer you to a documentary called How to Die in Oregon. And it walks through the stories of several patients who both have utilized that option at the end of life when they had terminal illness, and those who were curious about it and went through the counseling processes and chose not to use it. So if you're curious about those, I would refer you to great documentary, well done, over a controversial issue for which there are no easy answers. I thank you for your attention and your presence. Questions, real quick, if we have time for one or two questions? Or is there another class right at 2? All right. Thank you.